what is the result of um, we call it distortion of your system. Okay, the same thing that the mental health system helped you with, you can even infer from that your self-worth, relating to others, dealing with situations, and your life role. What is life role? Either we are we are working, we are in school, we are, even if we don't do either of that, you are engaging with others. It affects that. Ah, okay. So this is the episode I showed you this morning, the three buckets of emotions. So in depression, for example, because that's the one that you hear often, I'm depressed, I'm depressed. Okay. The word depression has been almost like we have a common usage, the illness and the normal sadness. Normal sadness, oh, it's been raining, it's so depressing, I'm depressed. That's not an illness. That's like saying I'm sad. That's normal. Normal emotion can also be it can be distressing, but it's still normal. For it to be about, there has to be change in your thinking pattern, in the feeling, predominantly depressed, and in physical symptoms of, okay, of sleep, appetite. Usually in depression, everything, your energy is low. So it's important what usually happens in real life. People go to their family doctors and go, doctor, I can't sleep, I can't eat, and the sometimes, or many times, they don't know that they also have to tell the doctor about the other two, the changes in your thoughts and feelings. And sometimes we don't ask. I talked about this morning how medical education doesn't um, adequately give tools to the general practitioners, which so they do the best, okay, but that's what we need to fight for, more education there. So all three of them. So if you stopped here and say, oh, this all I'm going to listen to, I'm going these buckets, right? If you go to see a doctor, don't wait for the doctor to ask you, how's your thoughts? How's your mood? How's your feelings? Is there any changes in them? Pour everything on the doctor's lap. Tell them everything. You will be advocating for yourself. Okay. So this is the picture I would like everybody to put somewhere. You treat the disease and not the episode. And there are many types of depressive disorders. So episode is like the building blocks of illness. Like I'm coughing, I have fever, I go to the doctor. The doctor doesn't know what to treat you for until he asks you other questions. A good example would be like migraine headache. There's no blood test for it, but it's the other things that go with the headache is how the doctor determines. In that, the average person knows that if I have a headache and it's, only half of my head, or I feel this, I see this, I should tell the doctor. So that is done. Unfortunately, in mental health, it doesn't get done. So I'm pleading, advocate for yourself and tell doctor everything. Now you have a depressive episode. We say it has to last for about two weeks or more. Okay, and it's affecting you. How do you find which illness it is? Because the different illnesses need different treatments. So this is I'm wondering what goes in many of you's minds when you see this mania episode. I've often said to my patients that if I had power, I would change that name because it is misused a lot. Okay. But what it means is the changes in the thinking is two things. Either it's like everything is rosy and there is no risk about anything, okay, or everything is looked at in a suspicious manner, okay. So either of those two, if those are the predominant changes, the other thing that happens in terms of, I talked about the ideas come fast, faster than your usual. And they are so fast and they are not orderly. It looks like the NASCAR, those who have watched on TV, the cars are weaving in and out. That's how the thoughts are. And what happened is, if you imagine the screener at the airport, the luggage screener, if all the luggage is just coming and jumbled, it can't be screened well. In the screening itself, the factory itself, what predominates is, again, it's the angry making ideas that are led to, or rosy, unrealistically positive. For us to function, we have to look at the risk benefit. In these two, those ideas are all ideas that don't have risk. So that is the thought process. And if someone comes says, I can't sleep, I just ask them, okay, tell me, how are your thoughts? And these are the terms they use. Oh, it's racing. Well, you can have racing thoughts that are problems, worries. So I said, tell me, are the thoughts that race through your mind, are they worries? Are they random? Or they are random, they jump to, oh, I'm going to go watch TV. No, I'm going to cook. When I'm going to buy something and stop, they are jumping. And in terms of the feeling depends on which one is predominant. If it's rosy, then the feeling is not just happy. Happy is normal. Overly excited is what you have. In terms of if it's the suspicious ones, then anger. And there are people, believe it or not, who are ordered from court to go to anger management classes. Patients like that. And I write to court. It doesn't matter what class they go to. It won't work. They're ill and they need treatment. Because even in the class, the teacher may say something, and that's looking through the suspicious lens, they can say something and get themselves in trouble. Now, in terms of what the physical expression of it is, again, the sleep. So now you see how sleep, when we are depressed, we may not be able to sleep. When we are in a mania episode, we can't sleep. Why? We only sleep when our thoughts relax, sleep, so we can sleep. In this stage, the thoughts are too fast to let the brain sleep. The difference between the person who is not sleeping because they are in a mania state where their thoughts are fast and not sleeping, say in a depression state. In depression, the thoughts are as tired as the body is tired. So even if the person is not sleeping, they are lying in bed, they are tired, they are withdrawn, they don't feel like doing anything. The person in the mania state, they're not sleeping, they're out at 12 midnight. They are going walking around. They are cooking. They are cleaning. And they will tell you, this is not my norm. I can't stress that enough. It is not their norm. It's a change from their norm. Now, in a depression mode or stage or episode, common knowledge that people get to a point where sometimes life feels so hopeless that they may think of harming themselves because they feel they are a burden. In the mania stage, people also can lose their lives. In mania stage, the brain is not trying to die. They don't want to die. But the brain can't make good judgment because the thoughts are coming too fast. It can't think about the situation. So impulsivity is one hallmark of this stage. People don't come to us and say, doctor, treat me, I'm in mania. No. You see them in the emergency room with broken bones, okay, a lot of legal problems, okay, fighting, impulsive, challenging people that they don't even know has a weapon. And people have said, Dr. Kankam, I can't believe it that 2 a.m. I got down and I was arguing with this person. That's telling you that's not their norm. So it is nothing fun that people say, oh, you're a maniac. No, it is not fun. Okay. Now, why is this important? Anybody who has depression, to know who has depressive episode, you are now in depression. Okay. To know what is the disorder, the disease to treat, you have to ask the person, have you ever in your life had symptoms of mania? Of course, you're not going to say mania, you're going to ask these questions. Why? It's amazing because it's when I use diabetes to explain, people get it. Anybody who has low sugar, okay, if you have low sugar, the doctor doesn't know what illness it is. Even if you don't use blood, even if you don't do blood work, if they ask you, are there times in your life when you are thirsty, you're drinking lots of water, that's asking you signs of high sugar. That person will know this person in a low sugar now, but the overall illness is diabetes. Same thing as this. Every time I use that, people get it. Okay, so that it is. If you have had depression, but never ever had mania, your illness is called major depressive disorder. And we all, including we psychiatrists, sometimes carelessly use the term you have depression. The name of that illness is called major depressive disorder, MDD. If you have ever in your life, it doesn't matter whether it was 10 years ago, 20 years ago, ever been an episode of mania, the illness is called bipolar disorder. And again, illnesses don't have the image you have. Somebody with diabetes, you have 5 people with diabetes, they don't look the same. 5 people with asthma doesn't look the same, okay? But they all have the same illness to be treated. So how you treat somebody who has major depressive disorder and how you treat bipolar disorder are different. How well do we do? Okay. Oh, this is a good graph. So this person, I hope you can see with my mind. If somebody came and they are in a state of depression, 2 weeks, we talked about all that episode, okay, and they've been asked, have you ever had the mania episode? And they haven't. This illness is major depressive disorder. Those are the ones that you've heard of, the Prozacs and the Lexapros and all the antidepressants that we have so many of them. That's what it treats. Let's say the doctor sees you in the second bout. In between when they saw you, you have had a mania episode. If the doctor doesn't ask you, now they're treating you for the wrong illness. Because now that you have experienced this mania, this illness is now bipolar disorder, and you are in the depression phase of bipolar disorder. Any person who is ever sat in my office one time, any patient, can tell you, Dr. Kankam, about the ceiling and the floor. My analogy is in depression, it's like your floor breaks. So we just need to patch it up. In mania, it's your ceiling that breaks. If you just bring something like a pole to move it up, sooner or later it will go up into the crack in the ceiling and then you crash down. So if you give somebody who is in a depression episode, who truly has overall disease of bipolar disorder, and give them your Prozac and all that only, they'll go, the depression will lift, and very soon you find them exhibiting the behaviors that we talked about. And sometimes That's how we actually get referrals in general practice. People will say, oh, this thing didn't stop work, this thing gave me side effect, but this is what happens. Sometimes someone is admitted to the hospital on a Friday, very depressed. You think it's major depressive disorder. Come 4 days later, they're taking over the ward. Okay, so it is very, very important. The message is, if you have ever had experience of mania, please tell the doctor. Okay, so how well do we do? And when I say we, this is part of what drives me to do what I do in terms of the advocacy. They did a survey in 1997, surveying people who have bipolar disorder and asking them how long did it take before they were correctly diagnosed. They did the same survey 7 years later, exactly the same result. It can take up to 10 years while you are still seeing doctors, including psychiatrists, to get the correct diagnosis. Some of the celebrities that have shared their story say, even if they see 3 or 4 physicians, including psychiatrists, and the number one wrong diagnosis is major depressive disorder, because that's what the person is suffering. That's, we take our suffering to the doctor. The symptoms of mania are not, they are not distressing. If I'm angry at you, I'm not distressed. It is the consequence that distresses, but the feeling of anger itself is not distressing. So it's very, very important. I can't stress that enough. People, these are the people who have bipolar disorder. Somehow, genetically, they are smart. They are, people, so that's why they are in Hollywood. No, they are creative. But like I said this morning, knowledge alone won't take you all the way. To get you, you need wisdom. And this takes away your wisdom. So, like I said, it's my platform. So this picture is sitting on my wall, because I'm telling you, there's no single week I go to work that I'm not having the discussion, because there's somebody who is come, has been treated for depression or think the depression for years. And then when we talk about past history of mania, then we find that it's not that kind of depression. So I have my young ones, some of my patients who ask for the T-shirts. They are my partners in sending the message. Depression comes in many types. Anytime someone is diagnosed, or if it's you ask the doctor, please, what type? If you go to the doctor, I'm coughing, and they say, take antibiotic, you want to know, what are they treating you for? Very important. Okay. So, I want to talk about suicide. I know I'm going to be talking about suicide later on in the month, I think in 2 weeks. But what is suicide? We all know it is harming, it is killing yourself, or doing something to harm yourself with the intent of killing yourself. Some people will cut, they call them cutters, at least in the US, the term the cutters. And they can tell you, no, I didn't mean to die, I didn't want to die, I just want the pain to go away. But suicide is to harm yourself. Now, again, there can be a whole session on suicide, but what I want you to say is, it is not that a person doesn't want to live. To live, these thoughts that I talked about that are balanced, give us, no matter how bad the corona is around, the world is not stopping. We still go out because the mind gives us hope. In depression, it takes your hope away, the thing that makes you get up tomorrow and go. And so, at some point, the mind starts to feel like, maybe it's not worth living. Most people will hold on to something. Again, you don't know most people's thoughts. So if you don't ask them, whether, I hear, oh, my faith, if I do that, I will go to hell, or my children, or this. I hear all kinds of things. And actually, those things that people say, we use it to help them hold on to them. But as the illness gets severe, there's a point of which it slips. That hold is not enough. And that's where we tell people dial 911 or the emergency numbers. Just like you can have chest pain. People have chest pain, but there's a chest pain that you dial 911 for. And suicide, at least in the US, is the number 2 killer of young people ages 10 to 34. Can you imagine? So this is middle school, young adults, and it's severe. And throughout the world, we lose about 800 people a year to suicide, 22 veterans a day, physicians, one a day, psychiatrists, we are number 2 list of the professionals. So doctors, you hear recently a doctor, and we don't say commit suicide. This is so important. It's not a crime. It's a medical problem, a medical condition or outcome. So those old terms of this person committed, they didn't commit suicide, they died of suicide. And the number 1 risk factor for suicide is a state of depression because of what it does to the thoughts. Okay, so it's very important. And there are other things that we can talk about, but it is real. So anybody who is in state of depression, we need to ask, are you having thoughts? And please, if you have, and don't ask them as if they done something wrong, because I've seen, not just parents, family members say, how can you think about this? All the things that we've done for you. No, that's like the fever of the illness. So please, okay. So we've talked depression and depression, mania, and the illness. We can't forget about anxiety. Okay. Anxiety, again, that comes in episodes. Everybody is anxious because of what's going on. That's normal. We talked about this normal. The basis of anxiety is fear. But again, when it's normal, it doesn't stop us in our tracks. Okay, we're still able to function. We know you are afraid, but there are about 4 illnesses that when anxiety is the predominant in the factory, so the fear can be the earliest. Those who are parents, one of the earliest is what we call social anxiety disorder. These are children who are sitting in class. They're not even trying to bother the teacher. They don't talk. They're not trying to call attention to themselves. It can be so severe. I've heard someone say, I can't even tell the teacher I want to go to the bathroom. And an adult was telling me when they were in class, they actually wet themselves because they can't. And if the teacher was to say, come to the board or come and talk, they are shaking and sweating. So it's more than just shyness. It is a disorder. And these are people, the difference is they are in school. It's not like they don't like people. They want to be with the group. It is the fear that you'll be judged. Fear that you'll be seen at not measuring up. Okay. And again, like anything, it can go from mild to very severe. Okay. There's also in children, the second one that starts earlier on in child is obsessive compulsive. And they'll tell you, I have these thoughts that go over and over and over in my mind. But they will tell, I can't help it. That they will tell, it doesn't make sense, but I can't help it. When we are well, we can refuse to do things or say something. But when we are ill, I'm unable to. Illness makes us unable to. The other one is generalized anxiety. People will say, I know I've been a warrior. Everything, there may be a problem, but the mind takes it to the next level. And it worries over every single thing. What else? Some people have what we call panic disorder. Now, in all the panic, in all the anxiety illness I've talked about, you can have an episode of a panic attack. It's full of, it's a set of symptoms. You short of breath. Most people think they are dying, so they go to the emergency room. But the attack itself doesn't tell you what anxiety illness it is, because all of them can have it. What happens with all these fear, people start to, we have phobia. You are afraid. So in the social one, you are withdrawing. You don't even want the teacher to see you. In the obsessive compulsive, the mind seems to, people do things over and over and over again. They may check things that they know they've checked 20 times. They want to stop doing that, but if they try, anxiety is so much they have to do it. And some people get late for work, okay, doing that. So anxiety, you know that, people know that it is, I can't help it, okay. In terms of the physical expression, again, the person who is anxious, who is in an anxiety episode and is not sleeping, they're not going to cook or do something. They pace it because their mind is so restless and it's so distressing. So you see, you can have 3 people who are not sleeping. Unless you ask the different things, you're not going to know which illness is this. So if you go to a doctor, I can't sleep, or even say, I'm feeling down, you recognize depressed. Remember, these days they say we are all so busy, we don't talk much. This is what I tell anybody I see. Say, doctors, they may be busy. So you know this so that you give it to them. We need the journey. We meet you at the station. You know, you come, I'm depressed now. You are in an episode of depression. You need to know the pattern of your life. Because how we treat our illnesses depend on what kinds of episodes and how frequently they have been. Because even the person, if you have, my analogy is this. Again, if you have a hole in your floor, you patch it. By the time you have 4 holes in your floor, you're not just patching it. It needs to be reinforced. So it's important to tell, no, doctor, I start with, I have this. Then in the past, when I was in college, I had this. The other thing I had, by the time you have this. And sometimes I show the patient, I say, what do you think this needs? It needs to be regulated. That's what we do for diabetes. We're regulating the sugar. So this is our pattern. So just not the station. It takes 5 minutes to listen to where you are. But, make sure that if they don't ask you, tell them. So why does the mental health system malfunction? In the same way, why does our cardiovascular system malfunction? Why does any of our system malfunction? 1, genetics. Most of the mental illnesses are in the same group that we call chronic diseases. Your heart diseases, your blood pressure, your asthma, diabetes. Chronic diseases means science hasn't come up with a cure. We manage it. And most of them have some genetic component to it. If your mom or dad or grandma had diabetes, you have a risk. Even if you haven't had it, you have a risk more than somebody who didn't have it. So the same thing with this. In the case of mental illnesses, it's not diagnosed. Even now, it's all hush-hush. But people say, my grandma, sometimes they'll be in the room for about 2 weeks or a couple of weeks, and they stop, they don't smile. You can get an idea from that. Or in the case of mania, they may say, oh, they have mood swings. Suddenly then they get angry and then they calm down. So sometimes it's just from the description. Okay. The other thing is life experience, especially trauma in children. Okay. There is so much trauma now. In this lockdown, or stay home, shelter in place, one of the things we hear is domestic abuse went up. Okay. Children go through a lot. If I hear the things that people, my patients, the things they've gone through, many of them, I tell them, you're coming to me for help now, but know that you're a hero. You're a hero of your life. You're a survivor. So life experience, different kinds, everybody is different, everybody processes. And sometimes people process it, they go on in life, but after a while, then it's like it's overloaded. The other thing is lifestyle or substance. Okay. What I'll say about it in terms of substance abuse, especially from where we come from, Ghana, it's easy to say, oh, oh, I'm here to tell you that sometimes, and I tell people, especially in this, in this system, that we have more, at least we talk about more substance than there. Some people, if they didn't use what they used at some point in their life, they'll be dead or somebody will be dead. Sometimes the substances is self-medication. They've been going through life, alcohol, that's how they're able to sleep or they're able to function. And so anybody I see that tells me, oh, I use marijuana, I use this, my next question is, what does it do for you? Because if you don't help them, treat what it does for them, we can talk all our book. It's not going to happen. Okay. So we need to also find out and treat both at the same time. Okay. We're almost done. So how do we treat? It's not just medication. People think we go to a doctor and they write medication. No. Counseling. Counseling is not advice giving. I tell you, insurance doesn't pay for advice giving. You can do that in church. You can do that with your friend, your family. People are trained to help you. Just like, when you go to the gym, your insurance doesn't pay for that. When you break your leg, you go to physical therapy, they pay for it because people are trained to help you get back. So counseling is very important. The reality is, by the time people come for treatment, they are beyond counseling alone. They need medication. I'm not going to go into medication. We have a lot of medication, just like there's a lot of medication for antibiotics, for different illness. You have medication for blood pressure. So we have medications, but to know what you need, the illness needs to come first. So you need to ask your doctor, what am I being treated for? It's sad. Some people have been in treatment for like years, 10 years. And I ask, what is your illness? And they can't explain, but they can explain the other medical illnesses so well. So please, if we don't tell you, say, doctor, please explain to me. Psychosocial involves a lot of things. It loves you support. Again, you need your support system. I tell people, if you have the best doctor, best counselor, best medicine, and you don't have support, that's not enough. You can see your doctor every day, see your counselor every day. You still have 22 hours in the world, and it is those people. So when I see family members or friends or loved ones come, I give them extra hug. Well, that was before the era of Corona. So because it's helpful to tell your loved one, hang in there. Hang in there, it will be okay. It is very, very important. Faith, nutrition, everything, it's holistic. It's not just one thing. So how do we prevent? We can't change our gene, okay? The genes we can't change. Early detection, appropriate treatment, and your social support. What distinguishes mental illness, the way society deals with it, and the other illnesses that I've used to compare is stigma. What is stigma? It's attaching some degrading connotation about something. It can be, sometimes it can be race, It can, in this case, we're talking about illness. There's even self-stigma that I didn't put here. Sometimes those who have the illness themselves look down on themselves because they've heard it so much. So one of the things that we help them to see is you are a very, respectable person like anybody else. You just happen to have an illness that you didn't call for. So you are no less than anybody. It's not, oh, what about that? Oh, if you need to those kind of, it doesn't help. Even you have institutional stigma. Look at where many in Ghana, it's getting better now, but in many developing countries, we still have the asylums where when you are ill with other illnesses, you go somewhere else. Even in the medical education, everything is taught to every doctor before you even specialize. In mental health, it's like, it's just a little part of it, so we fight in that. Religion, which is why I love your church, that you recognize that just having faith doesn't make you superhuman. You still are at risk for illnesses. And going back to the 90s, I had a standing offer to my patients, call me to your church, and I've been to many of the churches. And it's encouraging to know that church includes it in their health first. Cultural, okay, we know that, traditionally, we've seen the pictures of the prayer camps, people being chained. They think they're doing, it's about their awareness. Many of these places don't intentionally want to be cruel to the patients, the people who have illness. They think they are doing the good. This is a lady, Ankafo. Okay, so at some point in Ghana, they raided some of these prayer camps and brought them to the mental health hospital. And when I visited Ankafo about 3 years ago, this lady, before she came to the hospital, she was one of those who they left the sun, the rain. She was chained. Her legs were all sore. When I met her, she was still unwell. She was following me around, spoke good English. And so I took a picture. I wanted to protect her privacy. So I showed only that. You see, this is a young, smart lady, you can tell. So awareness is very important. But the good news, this is my last slide. The good news is in Ghana, I say Ghana, in some ways, the awareness, the advocacy in the last 3 years kind of is even beating US here. In the last 3 years, I've acquired many children. Many of these who are showing their faces, they are not hiding. Many of them are university trained, okay? Some work in banks, some, they are mothers. You see some of them now, they have YouTube. You can subscribe to YouTube. They go to the malls and they talk about mental health. They are not afraid, very articulate. And last year when I was in Ghana, this is Accra Mall. I had the day I was leaving, we had a lunch there. And my two favorites are, there's a couple here who are parents of one of my children here. They're not standing in the back, they are here. They are on the mental health platform. So, going forward. Okay. So, I'm hoping that those listening, each of you, I tell every patient I see, I say, okay, you get a piece of my certificate. Go tell it on the mountain. Go spread the word. So lastly, our mental health is part of our health. Please, let's take care of it. And when it malfunctions, when you get an illness, walk with your chest out. There is no shame. You have done nothing. You deserve treatment. Thank you for listening. And let's get the challenges, the questions.
Thank you, Dr. Kankam. The floor is open for questions. I wanted to begin by asking a question. You touched on something just for a second, but I wanted to know, how important is nutrition to our mental health?
Very, very important. In fact, as a large body of studies that are coming out that our body, all these organs are interconnected. You know, um, our gut produces serotonin. People, at least here, talk about serotonin, some of the medications, some of the theories about, say, depression, you know, about serotonin not working. We have a lot of serotonin production. So it's very important that the total, our nutrition, it helps our total body. Exercise helps. We get the endorphins. So there are many, our brain is not here and our body here. So to answer your question, very, very important. Just like we say nutrition is important, we're all beefing up our nutrition to fight the virus now. We know that's not the illness, but it helps us to be able to maintain, to fight, gives us a fighting chance. So it's very, very important.
Dr. Kankam, if I might ask something.
Yes, Pastor.
Um, my biggest takeaway from your presentations is the three buckets. It seems to me this is a summary of everything.
Mm-hmm.
If I get you correctly, it all begins with a thought, right? Which is the fact, which now is translated differently by the different kinds of feeling.
Yes.
And then it works out in some type of behavior.
Yes.
So my question is this. There are people who would understand what you have taught us and still fall into a pattern where everything will be related to in a way that is negative, like my wife was saying earlier on. What goes into deciding the health of the thought factory? What determines, because if that is the causal factory, when does things go wrong there? How do you maintain health in that factory is my question.
Okay. You couldn't have put it any better than you have. That's true. So what goes in? Some of it may be genetic. Just like our personality, just like the way we talk. You see somebody and you say, "Whoa, I can say today, wo papa. Oh, what's that? You know, and I will mommy. We like Nanso. You know, sometimes you see and say, you have the same pattern of walking. So one is genetics. But the important thing is, just like we can be walking, I was born to walk like this, but I can go to the gym if I have awareness. Okay. Just you looking at me and saying, "Oh, you walk sideways. Go and do something about it." That's not going to make me do it. If I feel like I am suffering as a result, that gives me the motivation to go do something about it. So this person that you call, they're always negative. That's your assessment. But what is the result? Let's say this person gets negative. They go to a job, and every time, this is not just an episode. This is their personality. This is their way. Personality is the way that we deal with life. Okay, and sometimes it's also from what we experience as a child or what we're influenced by. But you go and you find that at work you are getting in trouble. Okay. You get fired. Okay. You can't pay your bill. You can't do. Suddenly, the things that you convince yourself, "Oh, I can't change." Suddenly, now you need help to change. Either you do it yourself, go find, somebody to help you, or if you can't, just like the gym, you go for a personal trainer. In this case, get a counselor. What are we doing in counseling? It's the counselor is not just talking about the moon, the stars. There's a task. You want to change. I want to be able to have patience. So you need the person to tell you when somebody says this, what pops in your mind? Oh, what pops in my mind that he's trying to put me down. That's why he said this to me. And then I get angry. So we start to say, okay, is it possible? How do you know that the person had the intention? Remember, this person has come. That means they want to change. Change doesn't come overnight. Okay. So we come at that they want help. It doesn't come overnight. So there needs to be patience. So the person the information we need is in our thoughts. So gradually, okay, they try. The next time you said something, maybe it took maybe another 30 minutes or maybe an hour, and then they got mad. Then they change. Change doesn't come overnight. So the question is sometimes genetic, but there can be a change. When you are ill, you are not able to make that change until the illness is over. Then you can get to where you use those things. When I broke my leg, I couldn't do physical therapy. When they fixed it, now I can go to physical therapy. Okay, that's
a quick follow-up. Since you are talking in a church setting, what would you say to someone who says, "Oh, I don't need to go counseling, I'll pray"?
The fact that pastor is even asking, I want to hug you. Because I've had patients, not too many, thankfully, patients where they said, oh, my pastor said, I don't need the medicine. I just need to pray. But I know more and more. I think when they hear from pastor, like what you said this morning, you are still human. You are still human. When 2 or 3 popes ago, when he was very ill, I used that for a lot of the Catholics patients. I said, you see, the Pope hasn't done anything wrong. He's still the Pope, but he gets ill. He got this. But you need the prayer. It's not either. You need the prayer that the person, counselor you're going to see is nice, knows what he is doing, that has patience. You need the prayer. Even the medicine you're going to take. You can take Tylenol now for your headache and it's not working. You still need the prayer or whatever your faith is. It is very important at the time that we, this time, especially in this time, we need something to hold on to. If you're not holding on to your faith, it will be my alcohol or something. So it is very important. But coming from pastor, I am sure they are listening and say, I will go and I'll and pastor pray for me, that they know what they are talking about, and they bring out their genius. So yes, you say what you're saying and what you said this morning. You come to church, pray, so that you get a good person, and so that they listen to you and they ask you all the right questions.
And to that, I would say, Amen.
Then,
Amen. A couple of things, Pastor. The word of God, it says from Proverbs 11:14. The word of God says, where no counsel is, people fall, but in the multitude of counselors there is safety. And Proverbs 15:22. Plans fail for lack of counsel, but with many advices they succeed. And did you study a pastor? Woman adi Dr. Kankam up or back chapel on him for the casano. Near many, the word of God says you have to really identify what the issue is. If it's fear, God knows we are fearful people. That's how we're made. We have that emotion. And there's nothing wrong with saying, oh, I saw my baby through into me. And the Mamin Konko who be nominated in Kamabon Paye, Nani Pakro. Iradi amano ubia obetimi na and in a casa kama na intimacy the American. I've really enjoyed listening to my esteemed colleague Dr. Kankam and Pastor and Miss Ghana, Sister Come for me who much. I was so happy to see the two of you today. Well, I never and right that I can come say the or Casa when I'm see you. Yeah, Casa Saturdays you be share when few and yeah. And so when I saw the two of you, I was so excited. I get to see all my good friends, and it's a beautiful day that the Lord has made for me, and I'll rejoice in it.
And I want to recognize. I want to recognize that Dr. Shaw Taylor, Dr. Ruth Shaw Taylor, psychiatrist and my senior.
Thank you.
Yes, please go ahead.
Waka da say sa ensa na wonom no eno na ebua no ma ne sustain na manye antu me ka kire ni say nyame ne betimi aboa ne nti onyere no ho na wonya afa kire ni me ho ba me ho so me ka kire ni say wohia help o si da bi ede na betimi aye aboa ne bi still I so wohia help ede na betimi aye aboa no me da say
Thank you. Oh yeah, Ada. Oh yeah. Oh yeah, Amato. There, Obia weighing, Obia or ya adults. Now, Onya help. Knowing him there, Onya help. It's a very terrible place to be. Family members. But I also do be as in school. But don't know who there or dog for school. Because into my finding panel call for help. Just an anchor pedal. Okay. But you don't stop talking. Sometimes obi or her you probably be the tough love. Tough love and I will penyin some find a nimpana and can or your over. Now over nebia or your penyin but on your say tough love. Ni there, Eddie Akukudu Abakade. Stand call for helper, and I'll help my support you, but not to moments. Sometimes that needs to be done. If you were where, will be respect to be. Inti, oh, young corner, young course of when you and come on. So that be fear, that's what we do at home. Young for penny be on yan kakasa. But sometimes in everything, internet and sun as some and a worker there. Sometimes what's at the bottom has to fall out. Sometimes the BB base C. For some people, watch your wanna. That's when in Fiji just say corner can help or and now today Jemima. What's the name? Even the doctors, hospitals. Yeah, well baby impaired physician. In there when young doctor no on son or yeah. There will baby a yitum of friend or catcher in the hospital or caddy or your bed your license. She's a car echo for help. Into be able to but on ye easy. The easiest is Nipakona one casabum. But sometimes they be you know your addiction into in Sunday into just stop overnight. Ibenya, able to move from it, Ibenya seizures. But there are places that will go to more help. And you to know what one normal nipping because our cat get a help and will be recount with nature a year saying, or your inti so yan or there yes some yes ye casa cacra in there. Maybe a bibin tin or no more. Then a body addiction that's right there. Body in yama in duribi alcohol, no ye in dura ye could say opiates in there for flu. If you were what, more from many be, I will from many one can, many people may who there. Dentists, will be quiet dental, opportunity, now woman, oxycodone, and then dreamy. Studies to be show there. 1 week, effort. Sometimes no over the eye there, part of it. You don't take it, then you start to feel some discomfort to be a ekafa. And see, we the medical people have to be careful. Okay. In Sunday, Abia or Friday, Moko, baby, Moko baby name into Makasa Mano Masakaka. The next time, Untuma in a few years, when you 6, when you 8, Nefi, Untuminjay. But there is help. There is help. And don't stop talking about it. Don't stop. Aye. But,
Question.
Go ahead, Uncle Friends.
Yeah, maybe my question is madam who say me was a problem no say mental illness no. You say me say be a de me ye normal. Inti me dem who ebi a obi aso hunu enka nkyerɛ me approach me say be a we no ma wani mra wo ho so nti me dem who say me was a problem. That's it.
okay, very good question. Nti so wanyem there, baby, wadwen mo see usually. Wadwen o see odwen. Bibisa nyem there, oh, ade oya reho ai. Na enko there 1 week, 2 weeks, na vi aden oya reho. Nyem there on a year in the way I etin. Nyem there anufa itumakada. Nyim there about dwendwena memfi ewe dwumama anaso na ere ya ade wo fia ekegyina idema na ehu adekora ba ye wo ho na ehu de nti it's a change so ye wa ade ye dedawa ana onye change but oye change because the man sit down dedawo okay na wo bravo bi wo ho se ibi wo krampa BBNC Obiba, or say, my life is so great, but maybe I hope. Same way, so life can be great. Nay, asthma. Inti, even there, or yada, or sister, or your sister, or wide dream, or your sister, or who feelings in there. We raffle, and that time be our way for an time in a fee, a dream stand there, my dream. By the time of Obibo Honen on year early, think about pain. By the time, be a man yamayawa. Obiaru humayo, Obiaru who their pain, nobody can see our pain. By the time I'm limping now, the pain has been there for a while. Until Ochar net a pede, BBRN, or start EKG help. In now a cough too. Why do you know that? Hey, Minya Dinibiana. Ewa, I don't know what I ended up. Inti, or ye noticing, on any way kind of pay, know yourself. Ama also son. It's me who there. I'm saying, maybe you'll be asked the sitting room where, nay, I am the Makashamadin. On Yama there, what kind of cry or your so cry, and can't come, or Yamasron, or Yamasro. Ma pretend, oh, my stroke, but me there, maybe out, and then me that the oil may be full, but man can't. Into the change, it's a change from your usual self. Today, Pastor summarizing, change in your thinking, change in your feeling, then change in physical habits. Now, my pede, my stressing in there. Men can, and I want to show worship, man, kade. Oh, muhu bibi ochada or depressed. Muhu bibi ochada or because in you through. You don't know my thoughts, you don't know my feelings, so you can't tell me. You need me to tell you how I've been feeling. Because even if if you see somebody crying, you can't even assume there. Maybe he won the lottery. Tears of joy. Jadana comes in. Just ask, don't assume, good or bad. Yembisa, you know. But it makes sense.
Dr. Kankam, I received a question through private chat. If I know a young person that I suspect is experimenting with illegal drugs, how best can such a person be approached without making them aware that someone has reported them to me?
Very good question. You get a call, or even it could even be my patients. I got a call from mom or from auntie. Doctor, I'm going to tell you something, but it's a secret. The first thing we say is stop. Don't tell me. Because if I can't use that information, then it's no use, because then that's one more secret I have in my head. Okay, because I have to use it, because if the person comes and says, oh, I hear, or not even, are you using? No, I'm not using. There's nothing to show in anybody's face that you are using. So sometimes we work, sometimes I will help the family member to say, be strong. They may be upset with you that you are saying it now, but they would thank you for it. And if it's a patient of mine, I will work with the patient to say, it takes somebody who cares about you to stick their neck out and say that you need help with this. So not wanting the doctor or somebody to know. Part of it sometimes is because of you yourself, how you see it. The Oriya Nkwada Bonasam, as opposed to as a medical problem here, and let's go get help for it. So again, the communication, if it's say your son, your daughter, call and say, I sense something, there's help, let's go get help. I know it's not easy. It will not be an easy conversation for anybody, but approach it in that way. It doesn't always work, but it won't work if you make it like, oh, this one is a druggie, and all the things we say, Ghana, well, we are on them, so that's one way.
May I ask a quick question?
Yes, please.
And thank you for it's very informative. So it seems like you talked about the importance of early detection, and it seems like a lot of times what happens is we don't really find out about these things until it's kind of like already a little bit late. And in the morning you mentioned the review of system by primary care physicians, and it seems to me those are a little bit like screening, and it doesn't go into detail. Do you think primary care physicians should recommend maybe their patients to see a specialist like a psychiatrist to talk to maybe once a year, irrespective of whether or not they have a mental illness, to maybe help sort of go deeper?
Okay, and that's a very very good question. And even to add to that, what I omitted to say is the average age of onset of many of the mental illnesses is around 14. Per the book, per the thousands and thousands of people I've seen over my 30 years, they will tell you, oh, when I was in primary school, when I was this, and sometimes it's overlooked. Oh, yeah, just teenage stuff. You've seen the change, but it's difficult for you to believe that your child can have an illness like that. So sometimes that you have seen it. My message, and the message these days is, give the child the language to say, I'm feeling this. That's why that movie, I have to go and thank whoever made it, because sometimes children, my patients may bring their children, and they want to come and say hi to me. And some of them will say, oh, that is sad. This one is angry. They already have the language, as opposed to when we were young, we didn't have that language. Okay. So the early, just like school, they screen for, at least here, they screen for hearing, vision. There should be some part of school helping parents so that you can talk with your child. But to answer your question about primary care, now in the US, every primary physician and pediatrician is mandated to do something called it's called a PHQ. It asks you about questions about depression. The faulty part about it is, remember I said depression, you are in episode. It doesn't mandate them to ask about the meaning. So that is where that survey that said 1 it can take 10 years to get the right diagnosis, because you may go there, you're overwhelmed, you are crying, so it's easy for the issue about depression to come up. But unfortunately, medical education hasn't got to where it should get, or even the mandatory. If you do this, if you text, for example, if you test somebody and they have low sugar, no doctor is not going to ask about, isn't going to ask about the high sugar. So in terms of that, the hope that give the physicians tools to ask the screening questions. The reality is there are so few psychiatrists, even in the US, that has so many resources that if you are waiting, average wait to see a psychiatrist is like 3, 4, 5 months. And I say, if you are very ill, waiting 3, 4, 5 months, that's a long time. So the other part is recognizing, for any physician, recognizing when this now needs a specialist. After all, if your doctor is treating you for something, your heart, there's a time when they tell you, oh, go see the cardiologist, or your stomach, go see the GI specialist. So that's, in general, anybody treating generally know when this is above you. For mental illnesses, that's where we are. So my energy is spent with the community. So when she introduced me, my passion is it's community, learn it, go ask your doctor, I've been feeling these changes, what could it be? It's not, even in Ghana, we are getting away where you don't ask your doctor question. Otherwise, they will say sabi. So people would ask, because it's your body and you only have that one body.
That's all the question is.
Dr. Kankam, we have a question here that says, the Bible says, as Christians, we should not worry. As human beings, is it possible not to worry? And the second part of that question is, and if not, when does worrying become worrying?
Okay. Well, the pastor will be the best to see where the quotation says that. Definitely that is not my expertise in there. But pastor said something this morning about interpretation. I'm wondering if you survey any group of pastors who will say, in this era that we are in, they are not worried. Okay, it is normal. Okay, so in terms of it is normal now to worry, but we are made such that when we have our health, we have that worry part, but there's also that other part that tells us, oh, don't worry, the other day you were worried that you won't be able to pay your rent, and this happened and this happened. So that's the balance that I'm talking about. We are made for that balance. So the worry comes and the hopefulness comes. The point where worry becomes an illness, called the different anxiety illnesses, is the worry stays there and the other voices that says, oh, it can't come up. It's like worry has taken over. Okay. At that point, it's affecting you because those things that emotions help us. You are in distress all the time. You can't sleep. You can't focus. Focus is one major one. You can't focus because all you do is worry. At that point, nobody has to tell you that I'm not functioning right. The thing is, many people don't know that, oh, that can be an illness that I can get help for. So at the point where it is persistent, it is affecting your peace of mind and is interfering with your daily function. Same thing that will happen if you were coughing, you had headache, and it's every day and you can't sleep. You'll be looking for your doctor quick. We all do.
Okay, another question. You've got a lot of questions coming.
Good, bring it on.
All right. One question here is, what is the difference between menopause and mental illness or abnormalities?
Very, very good question, and thank you for asking. Menopause is a normal phase of life. It may be a pain to us women, but it's normal. You know, just like having your menstruation, it's a normal phase of life. It's a pain for more people, for some people more than not, but it's normal. Normal can still be a pain, but certain stages of life, sometimes we are at risk of having some illnesses. Okay, so not every menopause doesn't mean I have menopause, so I'll get a depressive illness, I'll get an anxiety illness. No, it's a stage of life. Okay, and if people, you have some symptoms, people will say, I'm sweating and I don't feel good. Symptoms, one cough doesn't make an illness. One headache doesn't make an illness. So the symptoms of menopause, so let's start with, it is not an illness. You can't get an illness. So in the same way, old age, getting old is not an illness. But there are illnesses like dementia that are common in the old age, but old age itself is not an illness.
Is there a difference between a psychologist and a psychiatrist? If so, what and when do we see either?
Okay. So that's a common question. So a psychiatrist is a physician first. You've gone to medical school. That's A psychologist is a PhD degree where they haven't gone to medical school. So the psychiatrists finish medical school, they could choose to go and do cardiology, especially in the heart, specialize in any of the specialty. Okay. Now, so that's straightforward. Now, part of the training, at least here in the US, of a psychiatrist, you are still part of the trained to do counseling. So when you see a patient, because you're a physician, you do everything that a physician also can do in terms of evaluating and coming up with the illness and treating medically. But in addition, you can also do the counseling part of it, which again is not just advice giving or go and don't stop worrying. That you don't have to pay for anybody to tell you that. So the psychologists, and there are many disciplines that can do counseling. It's not just psychiatrists and psychologists. There are nurses who, in their master's program, they are trained to do counseling. There are people who are straightforward counseling. They went straight and specialized. So there are many disciplines that will do the work of counseling. I like analogies. Your orthopedic doctor, your specialist doctor, in their training, they probably, taught them how to do the physical therapy. But when they are sitting there, the other people, physical therapists who can do it. So they send you to the physical therapist, but they know what the physical therapist is doing. So when I can use myself, because for like 2-3 years I have problem with surgeries and physical therapy. When I would see my orthopedic doctor, the doctor for my bones, I never leave without him asking, okay, what is your physical therapist doing? Is he helping you with this muscle? What is he doing? So because he knows. In the same way, when I started my practice, because I didn't have as many people at that time, I did all my counseling. Very soon, there are not enough psychiatrists, and you have many people who can do counseling. So the system is, we call it split treatment. There's the doctor doing the doctor thing, but let me quickly add, it is the psychiatrist. And you can quote me, they're not just there to say you can't sleep, here medication. How can they know what is wrong if they don't ask you how's your sleep? How do you, if you can't sleep, what happens? Are you worrying? So there is some amount of exchange, because we almost get the bad press that, oh, psychiatrist, oh, I know actually do. Well, advocate for yourself, because they can't know what's in your thoughts. So I ask my patients, and I intentionally use this word. I say, what are you working on in therapy? And if I hear, oh, we're talking, I say, insurance doesn't pay for talking. That's your friend. It's work, like physical therapy. There's a goal. It is painful sometimes, So to answer your question, there are many people trained, including a psychiatrist, but only psychiatrist is a physician trained in medical school.
All right.
Does that answer?
Yes. Three in one question. Someone with a depressive disorder and paces a lot, what can be done with such a person? Secondly, any specific diet recommended for a person with major depression? And third, how would you approach a person if you identify that she has depressive symptoms? Example, countless mistakes.
Okay, there's a lot, all great questions, because these are the questions we get in real life. And this is what gets me, I do these mini talks in my office almost throughout the day, because there's a lot of assumptions there. Okay, so there was somebody, I think I heard somebody who has depression, and then mentioned major depression. So depression, remember my t-shirts that I showed, depression is not one illness. So depression can go from, are you talking about the person who is sad today, or the person who is in a bout on episode? Sorry?
I think they said depressive disorder. I don't know if that's helpful.
Okay, so there's still many types of depressive disorders. So I said there can be bipolar illness, okay, that you have bipolar depression. So you have bipolar illness and you are now in depression, or you can have the major depressive disorder, which means you've never had symptoms of mania before. Okay. So I say the person is restless. That was it, restless, and what can you do? First thing is, and something we need to do more, ask the patient, why are you restless? There are many reasons why I would be pacing. It could be anywhere from, my thoughts are not making me, my thoughts are worrying, my thoughts are saying this, and I'm restless. Or it can be, sometimes even medication can have side effects of restlessness. Okay, so we don't ask enough. So the answer is, ask the patient, what is it? Because remember, whatever we do, we're doing from our thoughts. So that person can tell you what is going on in their mind at their restless. Are they in pain? Are they? The answer is, ask why they are restless. The second part is we talked about major depression. So the major depression will be the illness. And I have to emphasize that these illnesses doesn't mean that you are ill all your life. It comes in bouts. So I could be sitting here and have a diagnosis of major depression, but I'm well now. But I may have an episode in 2 months. Okay. So the goal of treatment is to try and suppress the episodes, because what we know is the more episodes you have, the more it's going to generate. Okay, that's where the early treatment comes. And what was the third? I forget the third one. What was the third part to the question?
Yes. The third part of the question was, how would you approach a person if you identify that he or she has depressive symptoms? Example, countless mistakes.
Okay, so that's jumping a lot. Maybe counting mistakes, that's the assumption that you don't want. Okay, so I'm thinking the person is in the office making mistakes. who is that person saying you must have major depression? That's why you're making mistakes. Let's say that the more realistic thing is sometimes those mistakes is what is going to trigger. And that person may know, they know that when I was, let's say, doing my accounting or doing this, my mind went to something else. And so I wasn't focused. Okay. And it is the outcome of that. Say their job is in jeopardy or they are getting in trouble with their boss. That's what usually they will talk to their family doctor. Really, that's what happens about that. I'm making mistake. And then in talking, I can't focus. At this point, that's not the topic, but I want to bring it up. Focus and hyper, the two are not ADD. They are not, at least when I talk US here, they will know. Can't focus and being hyper or restless doesn't at once equal to ADD. I have attention deficit. Focus is like saying temperature. There are many reasons why you will have fever. We have to explore other things. So that person who knows, identified, and making mistakes, and not because I don't know my math or I can't read or this, they know all that. If I'm talking to that person, they come. This is how I say, when you are working, what goes through your mind? They may tell me, when I'm working, then my mind is on my mother who is sick in the hospital, and I'm thinking that they may not make it. Did the doctor say that they won't make it? The doctor has reassured me. I know that this person's mind their thoughts are slanted in worry and depression can go together. On the other hand, that person may say, I'm working at my desk and my mind goes to tonight, I'm going to the bar, or tonight I'm going to the store, I'm going to Dr. Kankam. My mind is just jumping. And I would actually ask, is it jumping at the thoughts, random thoughts, or all worries, sad things? If you write them down and somebody saw it, would they say you are sad? No, they are just things that come. I'm going to cook this. That is the thoughts of somebody in mania. So in all this may result in making mistakes. But it's when you dialogue with a person, then you determine what illness, and then you prescribe what treatment with an S, treatments. But we jump, that's what we're trying to do. Don't jump to mistake. The same way the person who's in tears, don't jump and say they are depressed.
Two separate questions. These days, it seems that anxiety disorder is rampant. Is it because we are becoming more knowledgeable, or are we misusing the term? And the second person has a question saying, how do you know when you're having a panic attack?
Okay, so let me go to the second one first, because those who have panic attacks, they don't ask you whether, what they call 911 and they're in the hospital, they are emergency room, okay? Because one of the common experience is chest tightness, short of breath. And most people, you don't have to be in a health person to know your heart is here. So most people think they're having a heart attack. So they go, and sometimes there have been studies worth thousands of dollars before the emergency room doctor, they decide after you've been there several times, I had a panic attack again. No, I'm having heart attack. Sometimes people go through that many times before either their family doctor or the emergency room doctor tells them, no, we've done everything. This is anxiety attack that goes. So they don't wait around. And now the other thing is, the first part of the question that was asked is, these days you hear anxiety. Well, our words, we share medical terms with society. So anxious, I'm anxious about this. That's a normal emotion. Let's go to the illness. studies have shown that anxiety illnesses are one of the commonest, or if not the commonest, psychiatric illness in people who have never talked to any doctor about it, because people just take it as, oh, that's just me, and my anxiety is getting the better of me. Now, the awareness, just like we're doing now, I mean, with social media, with, internet, people now understanding that this can be an illness. In the morning, I talked about last year when your church invited me to the youth camp, and a young lady, I think she's in middle school, came to me. She recognized, she knows herself what the thoughts. She's smart, but she couldn't focus. She said, I worry too much. I was telling my parents, this is not me. There are times I worry. That is an illness. She knew, she said, my grades are going down. Okay. So the illness interfere. At that stage in life, her function is to go to school, be with her peers and with her family. She knows that she can't function. But because they can't read her mind, they can see her, she does what she needs to do. They don't believe that she has an illness. Oh, the man worried, but in Jessica, you don't pay rent, you just stay here, we give you everything, why do you worry? So the answer to that is yes, awareness. And that's what we are promoting, awareness, because it is not just about worry. We're talking about your thoughts, your emotion, and physical. Those three baskets together. And don't suffer in silence either.
Dr. Kankam, here's me again. I have something that has intrigued me for a long time, and I'd like to know what you think about this. My wife also has the same concern. It seems to me I don't know whether there is a section in the brain that deals with spirituality and mental health. I don't know. But at least from the Bible, when there are issues of demon possession, for example, you find people's voice tones can even change. And it seems to me that when people have mental health issues too, sometimes they can have these changes in their voice tones. And then sometimes you have people who are having mental health issues, and they are able to recite memory verses like crazy. Okay. What's the relationship between spirituality and mental health? Is there a region in the brain where things get together and get confused? If you can share any thoughts on this.
The brain is an amazing organ, and even science is still exploring it. But couple of things that I just want to. My ears are so sensitized to it. People don't have mental health issues. Some people have mental health illnesses, just like people who have heart diseases. So we want to put it the right way. Okay, so mental health illnesses, because it's a whole category of illness that have only focused on some. Now, you mentioned the one that sticks out, okay, when you say some people, they can recite. Now, let me take the bipolar illness. It's known that in mania, somehow the mind, I told you that the thoughts, the mind gets more creative. Okay, actually, there's a lady here in Maryland, in Johns Hopkins, Dr. K. Jamison. She's written a book. I mean, she's well known widely. She's written Bipolar Disorder and Creativity. So unfortunately, some people, when they start having the symptoms of mania, when it is not any illness, you can have, malaria, and it's not too bad, and you have malaria and you can't do anything. So illnesses come in the severity. But when you start, we call something hypomania. It means you are having the changes, but it's not affecting you significantly. some people during that stage, I have patience that in that stage, especially if you are in sales, you cannot talk anybody, outsell anybody, it just comes, and I see they have their awards, but it's not normal. At some point, because what happens is, think about what I said about the ideas. To make a good decision, you need to think through the decision carefully, all sides. When you have too many ideas, you are not able to, you don't refuse to, you are not able to look at it carefully. You have made a decision. So the ideas that are coming are so fast that some people will say, Doctor, my mouth can't keep up with my thoughts. It's coming so fast. Not only that it's coming so fast, it's jumping from one thing to another. And so if you are listening to that person, they're talking about this topic, and they go to this topic, each topic, it's a great topic, but their mind is going back and forth on it. If that person is doing some work, project, you see, he says, I'm having incomplete projects. They start one thing, your mind tells you to start this, so you have many incomplete projects. For that person, they can recite. I've had someone where they wrote a paper and the professor was so sure that they didn't write the paper because they know they're normal, they're average students. But now they write this paper where it's like out of this world. We also know that in the mania, people become hyper-religious. Now, how do you know that's different? Again, those who know them know that that's not how this person talks, religion. Okay. So it's more than their normal. A change in your usual self is the definition of the illness. So yes, the filter is there, but in that mania, it's like it's coming. The other part, in the mania stage, the other thing that happens is it may go from, oh, this person is very giving, to people get bankrupt. Even Hollywood, where they can buy the whole store, people can't be bankrupt because your brain is not allowing you to make good judgments. So these stages, you can have hyper-religiosity, you can have hypersexuality. In the mania stage, people can be sexually provocative, people can do things that they normally wouldn't do. How do you know that? I have people who are coming for therapy, guilt about things they did 20 years ago in that stage, because that's not them. That's different from saying, oh, yeah, we are for the boss, some don't do this. This person is saying, that's not me. This is not me. Okay. So it's very, very important to distinguish that.
Yeah, Dr. Kankam.
Pastor, real
Can
quick.
I?
Pastor, please, real quick. Please don't go anywhere because this question has you directed as well. We are in a quandary. We have 15 minutes left and at least 1 hour of questions. So I'm just looking to guidance from our leadership. Can we extend by half an hour and push to 5:30? And Dr. Kankam, is there time for that? Or should we try and wrap it up in a few minutes?
If you have the time, I have the time.
Well, I think that, we also have the time to listen and ask questions. I will give indulgence. If you are tired, I bless you. Go and rest.
No.
No,
I say, you know what? I do this. I say I owe my patients. Many of them have been suffering for a long time. I'm their voice. I tell them, So I am here. If it helps one person to say, I do not suffer. I did not call for this illness. We don't get ill because we're a good person or you're a bad person. We are human. So please, I'm so glad that we're having this exchange.
This is so, Pastor, you're next. I guess as Pastor is saying, we understand if there are those who have to leave for other reasons. Otherwise, right now we're going to make the decision to revisit at 5:30 and see where we look
Okay, I think it sounds good. So, okay, Doc, I have about 3 questions. And one of them ties into the question that Pastor Donko asked. Where do you put the line on the disease moral responsibility spectrum?
Okay.
Because a person is not responsible, morally responsible for a disease. If I am an alcoholic and that is diagnosed as a disease, it doesn't make, where do you put the moral culpability and the moral responsibility for that individual? So that would be my first question. Then my second one is related to the mind-body dichotomy, the mind-body, duality. Is it possible to study mental states just in the same way as you can study, say, cancer cells? Because the brain is a biological organ, but mental states are non-biological organs. Mental states is mental states or mental states, are they the same way like a brain, a physical organ? If it's a non-physical organ, how do you study non-physical organ, and what are the limitations of studying a non-physical organ? And can you have the same level of accuracy and the same level of reliability like, say, studying a physical brain component? So let me limit my questions to these 2 options. Very, very interesting things. Yeah.
So in terms of the moral,
Yeah.
again, I will refer to what Pastor said, the standard. Morals are standards by, say, the church morals, religious morals, they are traditional morals, they are cultural morals in each place. So it's the standard by which that society judges someone. Okay. Now, I'm sure there are people in any church who are held, who are, seen as of high morals. If that person has one of the illnesses that I've spoken about and in that state, let's say that person develops bipolar illness and is in a manic state and they are being hypersexual. Question is, now you're going to say this person is no longer a morally sound person. Hopefully, you're going to say, this person, there's a change in something. This person, there's a change. This is not what I'm used to seeing them. They don't act in this way. Okay. So this is a change, and science, I'm going to answer both together. Science has studied the brain. Like I said this morning, the brain is the one that produces these ideas. Okay, just because you open it, you can't see it. The other things you can't see. You can't see your migraine headache, right? You can't measure it. Okay, it is biological, which is why. This is why. How come the medications? It's from some of the chemicals. We know that there are chemicals that are involved in the function of the working of the brain, just like there are chemicals involved in the function of the other organs. That's how they make medications, to see what can by studying. So they are studying, but because you can't see it, okay, it's difficult for people, not everybody, it's because one, science did not know about the working of the brain. It lagged behind the working of the rest of the health system. So in place of it, we know that in the 17th century, people were being stoned for showing signs of mental illness. In Ghana and some developing countries, some people are stoned. Sure, you know that. For we are Bayfo, that's why people are being stoned for having dementia now. People are being, it's not seen as an illness. Part of it is the culture not understanding. Okay. So when you bring the moral, are you saying the person who has an illness has now suddenly become a bad person. But
No.
when you have your pneumonia, you're not a bad person. So in terms of the moral, it's what is done. In fact, sometimes that same person, when they get out of that episode, they look at themselves with the same perception that you are talking about. How could I? I'm no longer my Bible. I said sometimes that's the therapy we do with them. Now, my religion. I can't imagine that I did this being a Christian. You couldn't help it. Sometimes that is the part that you couldn't help it. You are the same, you are the same strong, responsible person. You go to work, and now for 4 days, you are in bed. You can't even take care of your children. You suddenly become an irresponsible mother. No, you were ill. So we need to start looking at mental illnesses. Illness there is not put at the end just for decoration. It's illness. And illness is what we can help and beget. And there's been talking about whether it's biological. No, genetic studies are done in, twin studies where twins who are apart, they were not raised together. And you find that there's more, if one has a certain group of mental illnesses, the twins also have it, that you can't explain it just by how they were raised. That's some of the, I'm not a researcher, but these are the ways that they study, one of the ways they study illnesses that are genetic, they are hereditary. And there are people, as much as, every church, there are pastors who have illnesses. I've treated pastors who have illnesses. They're helping people. They're human too. They're human too. It's just that, unfortunately, some of the behavior consequence of the illnesses make people embarrassed. Just like if somebody is drunk, the way they will behave won't be the way they behave when they are not. It's maybe embarrassing to others. They don't see it at the time. So I don't know if I answer your question. It's not a straight one because it takes, knowledge, habits don't go away just because the science comes. Okay. In the same way, many illnesses come when we had the Ebola, right? In the Ebola period, some people, and I don't remember what West African country, they believed that this was spiritual. Some of the health people were even killed because you bring in certain things. So not understanding has created a lot of myths, and it takes a long time for myths to go away. The good news is it's getting better.
Yeah, I'm asking these questions because, I know that we have church members, and as a pastor, I also need some clarifications which will be of use for me and also for my members. So in terms of talking about the morality aspect, at least on this platform, we are Christians. And as Christians, we believe that we can make use of other branches of knowledge. God is the source of all knowledge. So whether it's coming from science, it's coming from reason or reflection, we don't jettison them. But at the same time, we believe that our highest source of authority is the Bible. And we subsume every other source of authority, at least for us, to the Bible. Now, I asked the issue of the disease morality spectrum because now people are making case scientifically that homosexuality is a disease. People are making case scientifically that, some people have pedophilia, and it's like, it's inherent in their genes. Now, when you go to the Bible does not categorize these as just something rooted in biology. Although every behavior is rooted in biology, but in the Bible, there are moral components. And from a Christian biblical point of view, homosexuality, a person becomes morally responsible for homosexuality, the Bible condemns that in a very strong term, So where do that was my issue. Where do we place the line? Because if you tell me that I have malaria, I'm not morally culpable for having malaria. I'm sick. So can you categorize a homosexual person in the same way you can maybe categorize somebody who has cancer? Because, okay, cancer is a disease. Okay, you don't blame a person for having cancer morally because you have a cancer. And now people are making case scientifically that, even homosexuality is a disease. We can look at it from that perspective. It's rooted in biology, causation, and those things. So in your own personal view, in terms of these issues going on, where do we place the line between, the moral responsibility for a person's behavior? People have predispositions. In fact, every human being has predispositions. And as a pastor, I know that because of sin, we have different predispositions. A person may have predisposition towards a lie. A person may have predisposition towards maybe drinking or some other moral behaviors. But with all these predispositions, if you have to make a decision whether you follow those predispositions and then you commit an act or whatever, So that is the specific reason I was asking where you put the line between moral responsibility and then a disease.
So since I'm here, as an to share my expertise.
Yeah.
The first and not you have expertise in your religious morality. The first thing to put to rest is in our books, in our discipline, homosexuality is not a disease. There is nowhere in our books that says homosexuality is a disease.
Okay.
There was a time, I think back in the 80s, it was in, and as they studied and it became where it's only a disease if the person is uncomfortable. Right now, there is nowhere in our standards, no doctor can say, okay, my diagnosis, homosexuality, it's not there. So in terms of the other aspect, that's not my expertise. And I wouldn't, if you ask me about personal, I would tell you that I have met good people that would good in any other way that I would want them to be my friend, my colleague, without anybody putting that label. After that label is put on, there's the same people who were kind to me, who helped me, who do this, So in terms of, is this label, that's not my expertise. But we know that there are people, there are upright people who made choices that didn't stop them. If they were kind, they are still kind. But beyond that, it's not my expertise. I think the debate will go on, but just to put it to rest, it is not a disease. It's not a psychiatric disease. It's no longer. It hasn't been for a while now.
And this
now,
if
somebody comes and says, this is where it becomes says, I have these feelings, but I'm uncomfortable. It makes me distressed. Now that's the stress they are coming with.
Yeah.
So it's the same thing like the person who comes. I say, I get angry all the time, and I can't help it. You are helping them. That's where in therapy, helping them. If it was just stop, do this. I always say that insurance, if it was just one time and somebody changes, insurance will pay for one visit and no more. But they pay for like 20, 40 visits a year because a habit, you are exploring it, So that's my take on that.
Thank you very much, Doc.
You're
Thank you very much.
Hello. Okay, I just want to interject with a question. If you're finished, Pastor.
Yeah, go ahead.
Okay, thank you. This is one in the chat. If you live with a person whose behavior has changed to the extent that the person talks negatively about everything, Even neighbors around and visitors see what he or she does or sees. But the person won't admit that he or she needs medical attention. All that the person is interested in doing is watching movies. How will you convince that person to seek medical help? Always that person is attacking, cursing, and abusive, and always talking about other people. How will you cope with that person?
Okay. So there are two parts. How the person, so this scenario where the person, let's say your roommate, or and the word I heard was change. That person has changed from how they were to this person. So that puts it in the category of there are changes here. They can know that person's thinking, but they're expressing something that almost indicates that they're angry, and so they're cursing. Okay. And everybody's now become noticeable. So it sounds like this person may be suffering from some mental illness. Okay. In the same way that if neighbors can see me that now I used to walk straight, now I'm dragging my foot, I may have something in my joint. The issue becomes, it is so painful to me to go and get help, or if it's a distressing thing to me, and you say, I've been seeing you dragging your leg and you seem to be in pain. There's help. I'm more likely to go get help. If it's not painful and I'm dragging, it's difficult to convince me to get help when I'm not in pain. We take our distress to the doctor, not when we are not. And anger, like I said this morning, anger is not painful. The result of it, now, if suddenly, let's say this person, to the neighbors, they start cursing the neighbor out, the neighbor starts to maybe do something, going to fight the person, or the neighbor calls the police. Unfortunately, sometimes that's how people get help. They get past the point where they can recognize that they need help. So here in the US, and maybe in other places in the US, the law allows people to make bad judgments as long as you are not an imminent danger. There's a difference between imminent and potential. Imminent, what you're doing is about to make you get harmed. Then you can call the police on the person. And if you convince them that, this seems to be medical, not that the person is just, that's how they are, they take the person to the emergency room. Or in some cases, that person, anybody can go to the court, the district court, and make a case there and say, this person, we've seen a change in them. This is not their norm. They don't see they're doing this. They're wielding a knife. Okay, so that becomes immediate danger. If you tell the judge that I think one day this person is going to harm somebody, they're not going to give authorization to get them to get to the emergency room. But you have to prove that it's almost imminent, but the person is unable, because again, remember that it's our thoughts that make the decision. If their thoughts are such that you can't make good judgment, that's how we call involuntary. You go on involuntary basis to an emergency room, and then you are evaluated. And if they make a case that, yes, this seems like a mental illness, and your behavior is such that you can't identify that you may be a danger to yourself or somebody immediately, then you are admitted to the hospital. So you can be admitted to a psychiatric ward on involuntary basis. But the law, again, protects. The law has gone from back in the 50s here, where people were put in mental, the asylums of this place, the state hospitals, and people rights were abused, to the protection has gone to such an extent that sometimes getting help for your loved one or family member who needs help but doesn't realize that becomes difficult. Because even if you are admitted to an inpatient involuntary in Maryland, if you have not agreed to still say within 10 days, I agree to stay, a judge has to come in the hospital. They have to decide. You can have a public defender or your own lawyer. It goes on and on and on. So treating somebody who doesn't see the need to treat is very difficult. So now, how does that person cope? Okay, sometimes caregiver burnout, if that person is related to the person or they are their ward, sometimes it's difficult. And so sometimes we have family members who need their own counseling to deal with a family member or guide them because, I tell people, I'm not your family member. So I'm using my head. I'm not using my heart so I can treat you. But if I'm treating my child, I'm still using my heart and say, no, I don't want to go. And then you say, okay, they say they don't want to go. And it's difficult. So sometimes we have to help them, guide them to get help for their loved ones.
You truly, I see Chrissy, hold on one second, Chrissy, 1 second. How can you truly be there for your partner that has a severe anxiety disorder?
First question is, did you know that your partner had an anxiety disorder before? When you say truly know, it's like saying, how can you truly be there for your partner who has diabetes? Is it that they didn't have or has asthma? Is it that they didn't have the illness when you met them and now they have it? Or what you're really saying is they worry about everything to the point where it's interfering with the relationship. And that is where you have to have sometimes support to be able to convince your partner that this may be a medical problem. You're not the doctor, but this is not how you used to be. Now you worry about everything and you can't sleep and you can't even talk. Let's just go talk to your family doctor. Let's start with there, because sometimes taking a psychiatrist, even here, I'd always say even here in the US, becomes, oh, so you think I'm crazy? So first, let's go talk to my family doctor, and hopefully the family doctor will convince them enough because they have a relationship to say, oh no, this can be a medical illness. Go and, let me send you to a counselor. More people are in counseling than seeing psychiatrists. And you hope that the counselor know at what point that counseling alone is not doing it. So to answer this lady, it seems that it's so overwhelming. They can, don't worry, my dear, don't worry. It's no longer. That's when you are in you are not in an episode. So don't worry. Your partner is not able to hold all those hopeful things, reassurance. They can't. So that's the point where you say, let's go and talk to somebody and make it so that it doesn't feel like they are less than. That's so important, especially in mental illness. Suddenly you have a mental illness and then the next time you get angry, or oh, Nadanaba, the respect is so important. So that's what I would ask that person to do, knowing that it's not easy. And sometimes taking care of your family member or loved one leads you to have your own counseling to be able to cope. And that's okay. Sometimes the person who is in treatment, I always encourage, bring your partner in. But I I usually even coach my patient. I'll say, don't just tell them the doctor wants to see you because they don't know what you've said about them. Just say, invite them to your session, and any, competent clinician will hook them in, will make them feel they are part of the system. So that's what I would advise.
Hi, doctor.
Yes.
I had a quick question on treatment. So you had mentioned a while ago that there has to be kind of this holistic approach to treating, which looks at therapy plus prescription, nutrition, all of that. And I think I want to focus on on the prescription and the therapy. I think my mind works a little bit more binary. And so in my mind, I keep thinking, well, if someone has mental illness and they need medical treatment, some sort of prescription, then would that not be enough to deal with the illness? What would the therapy do? And so can you just explain that a little bit more? Because the other side being as well, if it's simply a therapy issue, then why would we then need any medicine at all? Why is it not one or the other? Why is it both?
Okay. So, and I get this question a lot, and I always jump because people know about physical, so-called, and I always say quotation, physical illness. When you have surgery on your leg, it heals, but to function, for that leg to function well, it heals, you need a physical therapy, and need a gym, and you need all that to be functioning. Now, let me take an episode, an illness like a depression illness. We know that in mild cases, when it's mild, therapy is helping your thoughts, almost those thoughts that used to balance, and you can think about something sad and your mind can go to something hopeful. The process of that exchange, your mind still has wiggle room enough to gradually, now I can think about it. When I think, the reality is most people don't feel comfortable to come until it's not early stage. So most people who are going to get help, they've passed through the stage of early. Those who are benefiting from, say, counseling only, they've had the severe bouts, and then maybe sometime there's something going on in their life. They know that counseling helps. No, I need counseling alone. But the person who is still, they go at the stage where counseling alone is not enough. Okay. Now, the medication stage, Pastor was asking, it's a chemical. We have said chemical imbalance and almost made it as if people come and say, can you measure? That's not what we mean. We mean just like you take medication for your heart disease because it is balancing some chemical work that is being done. All the treatments we take for different things, cancer, the pill is not working. It's not amount. It is regulating something that is no longer regulated. Okay. Now, why does therapy? So that's where the medication, and there are many different medications. Now, let's say an example. When you have headache, you may go grab Tylenol. The next person takes Advil. There's no reason why they took one or the other. It just helped you. Both of them work. The bodies that allows medication in the market, the FDA, have said all of them work, but there's no science that say this will work more for you than that. But sometimes the choice of medications also depends on what other effects. So let me give an example back to my Tylenol and Advil. If you have a headache, both of them help your headache. But if you have an ulcer, you know that the Advil may bother your ulcer. So you may avoid the Advil not because it won't help your headache, but because you also have some other condition that it may not help. In the same way, we may, for bringing you out of depression, there are so many medications. All of them work the same. Some may cause weight gain more than the other. So the person who already is worried about weight gain, you might not choose that. Okay. Gone are the days where there were only 2 or 3 medications. So everybody just what's in your locker. No, we look at everything. There are a certain group of medications that we call them antipsychotics. Those medications may increase blood sugar. So if somebody has a family history of diabetes or they themselves have diabetes, we have other options to pick. And this is what I do in my office. I say there are 3 groups. This group we have to be concerned about this. This group have to be concerned about this. This group. So when we're evaluating, it's not just your mental illness. We are looking at that review of systems. Do you have any problem do you have any allergies? Do you have any problem with your kidney? If you have a kidney problem, we are avoiding the ones that may affect the kidney. So that's how we pick and choose. In the same way, we can have two that do the same thing. There's no contraindication. One makes one more drowsy. If you're not sleeping, you may pick that. Not because it's a sleep illness, but it has a side effect of drowsiness. And so it helps. So picking and choosing is more than just, my friend is taking this, let me take this. Now, that's the medication. Okay, now, the counseling. Counseling, having a chronic illness. And most mental illnesses are in the group that I say chronic illness. Chronic illness is your diabetes, your heart disease. You are living with this illness for the rest of your life until science comes. If you're diagnosed with blood pressure, no doctor is going to tell you in 2 years your blood pressure is gone, or diabetes or asthma. There may be stretches of time when you are not having the acute symptoms. The illness is not gone. So dealing with that, it helps. You are still the family member. You are still the worker. You are still you are still who you are, carrying this stress. So therapy is helping you handle everyday stresses on top of this. You are still the mother, and remember, also even dealing with it, sometimes accepting the illness. Some people there are people I see, I don't see them again for about a year or 2. And they come back, say, Dr. Kankam, it was difficult to accept it. But not accepting it didn't let the illness vanish. So they were suffering under it until they come back. So therapy is to help us cope. Sometimes, even help our family members and loved ones understand and accept. Because it's the reality, that they don't understand, even when they want to help. So therapy can include family therapy. You say, how do you feel? What does it make you feel? Because, for example, that person who was, the question the other lady asked, who had changed and was cursing everybody out, when they got better from that episode, it doesn't mean that the consequence of it, that roommate was still hurt. They're still feeling something about it. So if it's like a couple, what you did, all the insults, they still feel it. And so therapy can be joined to help get through that. Because sometimes relationships have broken over illnesses, which is sad. So that's where the therapy comes in. Sometimes the therapy, one without the other, is still not the best.
Okay, that makes perfect sense to me. What I'm hearing is that to actually treat the illness is where you would need the medication, but kind of just dealing with the illness as a whole and all that comes along with it is where the therapy comes from.
Yes.
So then I guess maybe just as a follow-on to that, so it is pretty clear then that the mental illnesses that we've been discussing are actually chemical
Yes.
imbalances. They are not just you're not thinking straight, or I'm just having a bad day. This is a lot deeper than that.
Yes. It's an illness, just like the ones that I've discussed, and the life course is they come in episodes. Many people who come in, they have had many episodes. You hear these days that they say university campuses. You know, they can't. Their counseling center can't see all the people who need services. Okay, is it that there's something about you get to a university campus? No. Remember, the average age of symptoms. We can all have symptoms of anything, and we just go along with it. You know, my joint was aching. I just deal with it until you can deal with it. 14. Many people have dealt with it for years. And then you get to a place where there's more, you go to that stage in life, you're no longer under your protection of your parents, and, the illness has gone on for a while. There are things, there are decisions you have to make, and then we have more crises. So everybody that I see, I start with that graph, I start with my pen, I go a V, that's your depression. And then we start to go. And you see this squiggly. And you say it goes, and they remember, yes, now thinking about it, I felt that it didn't last, but it was definitely a change. And you see that you are seeing them for the first time, that they've had bouts. And, again, why suffer through an illness that you didn't cause? So my message, actually, you seem to be a young person, at least compared to me. So my message to the young ones is that we the old folks are set in our ways. You say to yourselves, I refuse to suffer under an illness that I didn't cause. I have a right to experience what modern medicine brings. Okay, when they find something to cure or to manage the coronavirus disease, we'll all be there. Okay, you're not going to say, oh no, I go to church, so I'm going to pray about it or this. No, I am worth getting help for myself so that I can do what I am, my intellectual ability, my functioning. That is not me. Sometimes it's so sad. I had someone years ago referred by the primary care physician. And one day she came and she said, Dr. Kankam, something is strange. I just don't know. So I thought she wasn't doing well. She said, I'm not used to feeling this way. All my life, I'm used to feeling not good. So this feeling of feeling good, I don't know what to do with it. I'm not used to it. It was sad, but it's true. Those who have been crippled for years, when you straighten them, when they suddenly have surgery and they are walking straight, life looks different if you've been crawling all the time. So anything that is different takes getting used to it. So my message is, please, if you're out there, you deserve to feel your quality of life, a better quality of life. And that's what we're talking about, a better quality of life. And just because someone can go in your thoughts to know it, and they are just looking at you, oh, you dress nice, looks good, what can be wrong? Well, I'm human.
My question here say, them so churches suicide on the 19th no. About women's ministry, one of the suicide. But no question by who said, if you are living one to me, I'm so.
Okay.
Where them who say, loved one is thinking of suicide, and here one question. And now the other one also here. So be illegal, we need paper, we need a mental health treatment. And then the third one is said, in case it said, we be what issue, but when to me, my uncle saw the car online as well. obetumi contact you personally na ya wa refer me to baby. It's my question here 3.
Okay. I hope I can hold all
Dr. Kankam,
3. Okay. The suicide. Oh.
Sorry. Just before you answer this question, this is our last question.
Okay.
I know I have an hour's worth of questions still for you. However, we're
going to do part 2 at some point.
Yes, we'll do another part 2 and 3 and 4. But after you answer these questions, if you'll feel free to wrap things up on what you would like to give to us, and then we'll come back and.
Okay. So all your questions have been wonderful, because these are questions that needs to be asked. Suicide, even us, medical profession, even in the mental health field, there was a point where it's like, don't ask, don't tell. We used to think if you ask, you put it in their minds. No. As science continue to research, you know that as the mind begins more and more to think, things are gloomy. It's almost like wearing shades and everything is dark wherever you see it. At some point, so it doesn't go from you wake up one day and you're killing yourself. The mind has been thinking maybe life is not worth living. So we have something we call death wishes. I wish I slept. Some people say, oh no, I'm not thinking of killing myself, but I wish that I don't wake up. You start there. The human being wants to survive. Oh, look at all the problems that are going on. So they're holding on to something. Oh no, why did I think that way? It's not in my religion. They're trying. And then as it gets severe, it's just like temperature that is 99. As the infection goes on, it's going to 100 degrees. Okay. And then it's like, oh, I wish somebody would do something to me and I die. And then you have passive suicide, maybe if I'm walking on the street and something happens to me. But all that, okay. And then they've realized that suicide thoughts, it comes in waves. It's not every day the person has these thoughts. So we teach anybody that we see with, and it's not only depressive illness that is associated with suicide. It is a big risk factor, but many things add to the risk. Anything that decreases your impulsivity, like alcohol, like even anxiety, different things, chronic illness. We grade something called, there's risk factors. So when we see you, we're grading you risk factor. If you live alone, your risk factor is higher than somebody who you feel supported. Just because people are around you doesn't mean that you feel supported by them, So we ask, who do you feel supported by? So you need to ask. We now know that if you are in a state of depression episode, illness, the mind will go to it. Just like that if you had a heart disease, the doctor is going to talk to you about when you call that 911 for what kind of chest pain. He's going to have that discussion. So it's okay to ask, are you having thoughts? Instead, are you having thoughts that you feel like you don't want to live? It's not a comfortable, this is my job, so I'm taught to do it. Asking your loved ones, your friend, it's not comfortable, but it's a life-saving question. Discussion. It's not an interrogation. It's asking. You try, see that you're depressed. I've heard that, when some people are depressed, their mind feels like they don't want to live. Have you had that? Have you felt that way? Yes. Let's go and talk to somebody. Show empathy is so important. Whether it's us in mental health, whether it's one, show empathy. Show the person you care so that they can share with you, and then let them know, let's go and do something about it. Let's go, because it's a sign that your brain is being over, your system, the illness is overcoming you. And the greatest risk of the next suicide is a previous attempt. And it shows that for every suicide attempt, every suicide that is completed or is attempted, people have tried many ways. That people I see, they tried in school, they didn't, they tried when they were in middle school, they took maybe 6 tablets. Nobody knew. In the past, even in the 80s, somebody would come to the hospital and say, if you really wanted to kill yourself, or we don't say that, but they'll say, if you kill yourself, you take more than that. Now we know just the fact that your mind goes to it shows the severity. So it's not, oh, they didn't do something big. Okay. So that's the thing about suicide. Ask. And you yourself don't make them think that it's something bad. It's an illness. You wouldn't think they did something bad if your temperature goes up and you were shivering. You think it's part of the illness. So it's a consequence of the illness. And get help quickly. It's a sign that it's getting bad. And there are times if the person has attempted something and you say, oh fine, no, it's illegal. Okay. So that's not just limited to mental health. It's like, it's not about being illegal. If you are or you're illegal in the sense that in a insurance, but because they feel there, so they come and say, I want to pay cash. And it's not the fact that you are illegal, it's a factors. Can you afford to pay? Now, there were times when there were free, and some places were free or sliding scale, to stay there, but reduce the fee. And hopefully the churches also can help and have a fund so that they can help until the person can stand on their feet and then contribute. That would be a good suggestion. I'm putting the pastor on the spot. And what was the third one? So there is help. It's how you pay for it.
Third one, yes, if you are not obedient to me and without question or personal issue, yeah.
What your man say?
I say third one, yes, say.
Your private.
If you are not panel or ferris or baby line, so but no question be or what.
Okay. So okay. So right now, after about 25 years, and I decided that the business part of medicine, I'm done with it. So now I'm an employee in a hospital. And see, if you need help, we take mainly, there are some everywhere, there are some insurance that you take, insurance that you don't take, that the hospital takes. When I was in my practice, and I took almost all the insurance. And see, you can still call a hospital. I can give the number 410-350-7550 or your MedStar Harbor Hospital. You can call Baltimore, and even if on year my